And welcome to the 33rd meeting of the Health, Social Care and Sport Committee in 2024. I've received no apologies for this meeting. Today we consider our scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill at Stage 1. By virtue of Rule 12.2.38, Liam MacArthur MSP is able to attend if he wishes. The first item on our agenda is to agree to take agenda item 4 in private. Are members agreed? The next item on our agenda is to take evidence from 2 panels of witnesses as part of our scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill at Stage 1. We begin our scrutiny today by taking evidence from organisations representing healthcare professions to consider the impact and implications of the bill for those they represent. I welcome to the committee Dr Ian Kennedy, Chair of the Scottish Council, BMA Scotland, Fiona McIntyre, Policy and Practice Lead Scotland, Royal Pharmaceutical Society, Colin Pullman, Executive Director, Royal College of Nursing Scotland, and Dr Chris Provan, Chair of the Royal College of General Practitioners Scotland. And we'll move straight to questions, and Carol Moulkin.
Thank you, Convener. Thank you. Good morning to the panel, and thank you for joining us this morning. I want to start off by talking about the way in which the bill defines someone as terminally ill. And people may, I'm sure will have read that this in the bill currently is have an advanced and progressive disease, illness or condition from which they are unable to recover and that can reasonably be expected to cause their premature death. Now, there have been mixed views and evidence around that definition, and I wondered if I could ask the panel, with their knowledge and experience, how they find that definition, or if there's another definition they would refer us to, or might have views on what should be added or taken away in that definition. I'm happy to take from any order.
Hi. Good morning. My name's Chris Provan. I'm a GP in Aberdeen and work 2 days in a practice in Aberdeen, so I've experience of these types of palliative issues. Just to say that our organisation is opposed to a change in law on assisted dying. Today, however, I will be looking at the broad range of views within our member organisation and trying to represent them and really think about the practicalities of these types of bills and implementation going forward. The definition is not one of the areas that we have significant concerns about. It appears to actually contain many of the themes around how you define this issue. It's relatively narrow without giving a time scale, so I don't really have much else to say against that. I think it's important that over time we don't get a change in the definition without a review of the situation, potentially, as may have happened in other countries.
Thank you. Would other people come in? It'd be helpful.
If there are college nurses, people know that we have a neutral position in relation to the proposals and have had a neutral position for a number of years. In relation to the definition, it's not something that I'd want to add any comment to really in relation to it, because I wouldn't want any comments misconstrued, if you like. So the point of view that it's not something that we've had deep conversation with our membership about in relation to our discussions at the moment.
Does anyone else have a view?
Yeah, good morning. The Royal Pharmaceutical Society holds a neutral stance on the principles of assisted dying, and we haven't looked at the definitions of terminal illness in the bill. We don't hold a position on that.
Thank you.
Good morning. Since September 2021, the BMA has taken a position of neutrality on assisted dying. And this means that in my position as Chair of BMA Scotland, that I represent the view that the BMA neither supports nor opposes a change in the law. However, any change in the legislation would have a significant impact on doctors, and so we at BMA Scotland have a responsibility to protect and represent all our members, and that includes all doctors and medical students. In terms of eligibility and terminal illness, the BMA has not discussed this, but when we've looked at the bill, we do have a problem with the word premature, and we think that that is ambiguous. Normally the word premature would be used to mean... Yeah.
On to other parts of the bill, and
Okay.
other members have got questions. So if we could just stick to the question that the member has asked.
Yeah, okay, so we haven't taken a view on that. Thank you.
Do you mind, could I ask, would, in other areas of medicine, would there be a particular definition that the BME would use as terminally ill?
Off the top of my head, I can't remember ever the BMA ever discussing this, so I think the answer to your question is no.
No bother. I have one other question which may be similar, just given the answers that you've given, but I wondered if any of the organisations have discussed with their membership around the age definition that is in the bill, around the 16 years old, and also given that some legal experts have talked about safeguarding, but also 60-year-olds in some other areas are under 16 are deemed competent for healthcare issues. And I wondered whether any of the organisations had discussed this.
Well, it's still on, so I'll keep going. No, the BMA has not discussed the age criteria and specifically the difference between Scotland and the rest of the UK, the age of 16, so that has not been discussed.
Okay, thank you. Do any of the other panel have anything to add?
We've not discussed that in particular, but we have discussed implications, because of course that's what we've looked at as a college in relation to if there was a definition that it was 16 upwards, that would of course bring many more health professionals involved in relation to it. That's the only aspect that we'd considered.
So again, we've not, in the Royal College GPs, specifically discussed the 16 age limit. I think, again, there are concerns about those opposed to a change in the law around vulnerable patients was the highest concern. A fundamental shift between the doctor-patient relationship, supporting palliative care, and we may come on to this around capacity and things like that, because it really fits in the 16-year-old to some extent around capacity and those types of issues as well. But we haven't taken a specific issue on the age limit.
Thank you, convener. Don't have
you.
any other questions.
Gillian Mackay.
Thanks, convener. As the bill is currently drafted, is there enough clarity on whether assisted dying would be considered a reasonable treatment option? And if I could go to Dr. Kennedy first, if that's okay.
Could you ask the question again, please?
As the bill is currently drafted, is there enough clarity on whether assisted dying would be considered a reasonable treatment option?
Okay, so the BMA position is that in the conventional sense, assisted dying would not be regarded as a conventional treatment option.
Does anyone else want to? Nope. Sorry, give me a wee second. We've seen in foreign jurisdictions like Victoria and Australia where doctors are restricted from initiating discussions about assisted dying. Patient autonomy is often emphasised as the reason for that, but on the opposite end of the spectrum, Canada allows doctors to raise the option proactively. In your opinion, what would be the most appropriate approach in Scotland to ensure informed decision-making without undermining patient autonomy, and should the bill explicitly address an obligation to ensure access to assisted dying if the bill were to be passed?
So the BMA's position is that doctors should have the right not to discuss assisted dying, but they should not be penalised in any way for raising the issue. So we wish doctors to be protected whether they wish to raise the issue or decide not to raise the issue. And both aspects need to be explicitly recorded.
Yep, Dr. Provan.
So, again, I think we are very clear that there needs to be an ability for doctors to opt out of these types of being involved in these types of situations, not having to justify why they don't be involved. Balancing that against really access for patients if there is a service, but the key thing is having conversations about a range of services and available to patients, so they're aware of palliative care and all their options, but want to emphasise the ability of doctors to opt out. We are in favour, I mean, we come on to this with an opt-in system, so that there's experience of having these conversations and time to have these conversations and the infrastructure around that.
Colin.
I think so. I'm sure we'll come on to the kind of consideration of opt-in, but I think the important thing for this is around about access to information, both for patients and for practitioners, and that to be independent information in relation to, so that if the bill were to progress and were to move forward, we'd be very keen that should be provided in an independent way, so that people have independent access to that information, so they can make an informed decision, and then that takes less pressure off individuals in relation to it.
That's great.
Yeah, thank you. The only point that I'd make around pharmacists is that whilst pharmacists are named within the bill as a named healthcare professional, the role of the pharmacist is unclear, and it's only mentioned that a pharmacist is one of the 3 professions that can accompany an authorised practitioner at the assisted dying point. So in terms of bringing about those conversations, the role of the pharmacist isn't described other than accompanying the authorised practitioner. That's the only mention of the pharmacist in the bill at the moment.
Okay, thanks, Convener.
Can I just ask a quick supplementary to probably more to yourself, Colin, and I put on record I'm currently registered with the NMC, and I have a bank nurse contract with Glasgow and Clyde NHS. We spoke specifically there about medical staff, but obviously nursing staff play a huge role in MDTs, particularly in inpatient settings, but in community settings too. What consideration is the Royal College given about nursing staff being involved in those conversations?
Back to that point, we believe this should be an opt-in system, so that people who want to, who wish to support should be able to opt in. We'll come on to that, I'm absolutely sure. But the issues around about it comes back to this year about there shouldn't be undue pressure on professionals to have that conversation, because some people will feel very uncomfortable absolutely having that, and the actual because it moves on beyond that, the actual, not only about conscientious objection, for example, but it comes on the point of view of around about people who potentially could find that mentally harming to have that discussion. So that's why there shouldn't be a duty on people to have that conversation, in our view.
Thank you. I'll now move to Emma Harper.
Thank you, Convener. Good morning to everybody. Just a reminder to everybody that I am still a registered nurse as well. Perioperative background is my experience. It's on the conscientious objection. I'll come to you, Colin, just because you mentioned it. Is there enough clarity as to which staff and activities would be covered by the conscientious objection clause in the bill? It's only like 2 parts in the bill talk about conscientious objection. Just wondering what your thoughts are about that.
No, we don't actually feel there is enough clarity in relation to that. And I think the issue is that the inclusion of conscientious objection is important, of course, but it doesn't, for our view, currently offer sufficient protection that staff should be able to object to being involved based on conscious or for any other reason, in our view, because people will have different reasons for not being involved, and it shouldn't be that they should feel compelled to be involved. So we think that should be widened slightly, but again, we'll come back. If you had an opt-in system, that would make it much more clearer that individuals could opt in to participate in the process itself.
And as the convener mentioned, registered nurses are part of the multidisciplinary team as well. So I suppose to widen that in carers as well, carers at home, if conversations turn to, you know, I want to end my life, for instance, if somebody is really at the point where they, you know, they want to start talking about it, how do you feel that we should be more inclusive in the language in the bill to protect other members of the multidisciplinary team?
I think it should actually be very, very clear that anybody involved in the process, healthcare professionals who are involved in the process, shouldn't be compelled, and it should be the issue around about, I come back to about provision of information and support. That also comes to the next thing, I'm sure we'll move on to that, is about how services are set up, and if there is specific services, because then it would give access to unbiased information for individuals making an informed choice. People shouldn't feel the absolute requirement to have the conversation, but they should know where, if they don't feel comfortable or indeed trained, because these conversations should only take place with people who have the sufficient training, knowledge and understanding to be able to do that. So that in itself comes into the provision would have to be about specialist training for individuals to be involved. But again, that comes back to the support that's put into play for everybody involved in the process, regardless of their profession, I have to say.
Okay. Would that include pharmacy as well, Fiona? I saw you nodding.
Yes, absolutely. So we believe that the ability of pharmacists and other healthcare professionals to express their right to conscientiously object is of vital importance. And you asked particularly about the description of the process in the bill. And we find that the process that's missing within the bill is around all of those processes that support the safe and effective use of the substance. There's no description of the storage and distribution, the dispensing, the prescribing, and, if necessary, the safe disposal of the substance. And our understanding is that in order for the conscientious objection clause to operate, then that detail needs to be included within the bill, and that will then cover all healthcare professionals that are involved in all of those processes surrounding the management of the substance, and the details of that need to be described right the way through the process. So we believe that detail needs to be added to the bill.
Okay. Yeah, Dr. Provan.
Thanks. So the Royal College of GPs really opposes the current drafting of Section 18 around conscientious objection. Very clear that we shouldn't have to justify or prove objection or not wanting to be involved, and should be some wording around it should be unlawful to discriminate against anybody who's made that decision not to be involved. Maybe opt into certain parts which might allow flexibility around this. Mention an opt-in service model which eliminates some of these difficulties. GPs, I think, are worried about being caught in the middle in this process. There's potential for moral distress in any clinician involved in this because it's complex and an emotional issue, naturally. A lack of agency in trying to make the best decision for patients, and conflict with ethically what they've been taught or brought up with. So 30 to 50% of clinicians involved have an emotional burden or discomfort with this type of thing from other jurisdictions. 15 to 20% an ongoing significant adverse personal impact. So we're calling really for support for mental health, also for patients, for families, for doctors, and all the team, as you've mentioned, around this. This, just to emphasise, this is in a background of low morale and really a stressed primary care at the moment, with 55% of GPs say that they're struggling with their workload. So we run the risk of losing members of staff if we're not careful about how we implement this if it goes ahead.
Okay. Yep, Dr. Kennedy.
Thanks. Yes, the BMA has a concern about the conscientious objection clause, and we feel that doctors should have a general right to object to take part in any aspect of assisted dying. We have a range of views across our profession, and even those doctors who are willing to participate in assisted dying, they're telling us that they also wish to be able to object to taking part if they so choose, because of the distress that they may feel. And the activities that doctors who may not be supportive of assisted dying may be asked to get involved and include giving an estimate of life expectancy, making a capacity assessment, or assuring of freedom from coercion. So really important that there's a general objection to being involved in assisted dying for doctors across Scotland.
Okay, thank you. Thanks, Convener.
Brian Whittle.
Convener, good morning to the panel. There have been, during our deliberations, some concerns about what we would deem to be suitably qualified staff, how we would maintain safeguards, and how we would avoid, somebody seeking several doctors' opinion till they get the answer that they're looking for. So, can I ask then, in the first instance, who should lead and who should be involved in providing assisted dying? I'm going to come to Dr. Provan first, if I could.
Thank you. I think it's a complex situation, and you're trying to really think about the patient's capacity to make that decision, which in itself can be complicated and take time to do that. You're trying to make sure that there's no coercion, which again is time consuming. So I think we would be in favour of there being a separate service to do this, so that those people have bought into the service and are used to actually going through this process with their own protocols, so that we get the best service for the patient. Trying to add this on into a busy general practice is really very, very difficult around the subtleties and the importance of these types of situations, and coming back to the point about we'd like a central source of information so that patients have independent information. Again, GPs are concerned about being caught in the middle around this on their decision as to whether a patient is eligible and whether they have capacity, which clinicians can disagree on. You may need to involve specialists. I was very surprised to see in the bill and the notes around it that this could be added into an extended consultation. The complexity of this cannot be added into an extended consultation. You had also some evidence from Australia, I believe, earlier, and one of their comments, I think, was that this doesn't work so well in busy practices. There really is no such thing in Scotland as a quiet practice. There are some areas where there's not many GPs, which is why we think for the system, for the patients especially, for everybody involved, clinicians, that we need a central service to run this.
Can I, Mr. Pullman, where do the RCN sit with this?
In relation, Bill, clearly it's indicated that it would be medical practitioners that would be making the assessment, but as we've kind of alluded to before, the multidisciplinary team will assist in that quite clearly. So in that in itself, and I share Dr. Provan's position in relation to provision of service, and that time should, this will take time, and if it's done in the right way, in the correct way, if it were to proceed, yet, these are really complex decisions to be having with patients. They're not easy discussions to be having with patients. So, at the end of the day, as I say, it would be the medical practitioners that would lead these assessments, but they would be supported very heavily by the rest of the multidisciplinary team who are involved with the patients, I would imagine.
Yeah, before I come to you, Dr. Kennedy, I suppose what Dr. Provan and Mr. Pullman have been alluding to here is the potential impact on the day-to-day running of our health service, which we know is under a bit of pressure. So, where if I could add in the sort of complexity, if you like, of what happens to how this impacts the running of general medical practice, and how that would how that would obviously, from what you're saying, Dr. Provan, would be a detrimental impact in any GP surgery. But I've come to you, Dr. Kennedy, just to expand that out.
Yeah. So the BMA doesn't have an opinion and hasn't discussed what the service, if one starts, would look like. But we're absolutely clear that it should be a separate service and it would require additional new funding. And this is, if assisted dying happens, it's going to be a rare event, it's complex, it's going to require specialist training and guidance. So we would envisage only a small number of doctors in the country who would be willing to provide the service and willing to undertake the training and develop the expertise. So we very much see it as a specialised separate service, and absolutely not something that would become the standard role of doctors across Scotland.
I'll ask Ms Marketer, where do you think the Royal Pharmaceutical Society, where does that fit into this sort of jigsaw?
Yeah, I agree with everything that has been said already. And the role of the pharmacist goes far beyond only the supply of the medicine, and pharmacists are within multidisciplinary teams across all care settings. And I think it's important for patients that they receive care from healthcare professionals that are highly trained in this, and that they have the appropriate time to be able to deliver this care and are comfortable taking part. In terms of how the service will look in the future, if this bill is passed, the Royal Pharmaceutical Society haven't come up or discussed what that would look like, but we are in favour of an opt-in situation where you have a network of healthcare professionals that will be able to deliver that service. And pharmacy services are experiencing similar challenges to other parts of the health service, and it is difficult to see how this could be accommodated within our current provision.
Can I just ask one small one thing that they said there, this should only be delivered by highly trained. Now, I would argue that all of our healthcare professionals are highly trained. I suppose then it comes down to experience, and obviously somebody just qualified is a very different level of experience as somebody who's been 10, 20 years in the healthcare profession. So I think that's something I would, from your perspective, Dr. Provan, how would we define highly trained?
Yeah, I mean, you can do many forms of training for this, and GPs already are skilled in assessing capacity, and part of that is around coercion. But I think in these quite unique situations, initially especially, it would be better to have people who are used to doing this and have the time to do it. Doing an online module for 6 hours doesn't necessarily equip you or give you the time to have these important conversations with patients and make sure that they get the best service. You would have to have, obviously, protocols around the medications and what to do in certain situations, and we would want a central service to hold these, so there's consistency of that and information available in obviously different languages and different formats, so patients are well informed.
Just if anybody else has got any comment to make.
Can I just make additional comment? I think the issues around about, of course, our healthcare professionals are highly trained, but it's about specialist training to support them in this process. This would be completely new in relation to their practice, so they need initial support and training, but they would also need continued professional development in relation to that, as well as the continued support in participating in the process. So all the psychological supports and everything that we need to go with it. And that's why I think the consideration of a service, what that would look like, whether regionally or nationally or wherever, I think that's for further debate elsewhere. But the point of view is to make sure that people that proper safeguards in place and people are properly trained to support individuals if it were to go forward.
Can I just ask a bit of a follow-up on that then, with regards to the financial memorandum that comes with the bill? So the estimates for staff training there would be £200,000 in year 1 and then minimal year 2 and projected to be minimal in year 20. Do you think that's realistic?
If that's directed at me, no, I don't. I think it is realistic on the longer term. I think because it will make a big decision in relation to whether you have an opt-in service. So if you were an opt-in service, clearly it'll be a specific number of people who opt in to do it. It would be much lower than having to do generic training. You will have to do, of course, generic awareness training for everybody in relation to health and social care, indeed, across the way. But for our point of view, it depends about how the service is. We actually responded to the committee in relation to the finance memorandum, say that we don't believe that it is sufficient as it's currently set out. But that obviously would have to be worked through in relation to what the service would look like. And so when you would look, you'd be looking around about the numbers that you were going to be training, and of course the detail of the training that's going to be provided, because that would yet to be decided.
Okay. Chris?
Thanks. We also think it's an underestimate with the current model proposed, training everybody in this situation. Again, you could do an online module, but that doesn't necessarily equip you for the real world. You have to then go out and gain experience around doing that. GPs have a lot of experience, as I say, around capacity and coercion, but this is a specific situation. So there are other costs around continuing professional development, and reflection on how the system has worked, and learning, which is not really reflected.
Thank you. Joe Fitzpatrick.
Thank you, Convener. We almost went on to this area in the last question, but I want to ask about coercion. It's one of the big concerns that even people who support the bill are concerned about the issue of coercion. So the first question is around whether you think that health professionals have the skills to identify if coercion is happening and it's taken place. And the second question is whether the model that's suggested in the bill is the best way forward. Last week we had witnesses suggesting that an alternative system that would be better was one using independent assessors, similar to what's used for Human Tissue Authority in terms of living donors, to make sure coercion isn't there, and that would provide stronger safeguards. Is that necessary to have those stronger safeguards, or have you already got the skills within your team? And Dr. Provan, you almost went onto this area in the last question. So.
Absolutely. I think GPs know their patients and are skilled in knowing the patient's background, but I don't think they have the experience to detect coercion in every situation. And they don't have, as I've said before, the time and the space and the headspace to be able to do that in the current model. Partly that would be helped by having a centralised model where you have independent doctors or a team assessing the patient. There will be some situations where it is obvious and we're trained in adult support and protection, but that's a complex, time-consuming area. And sometimes it's quite subtle. Somebody feeling that they're not under coercion, but just feeling that they're a financial burden to their family or something like that, it's quite difficult to detect with that. And our concerns around vulnerable patients in that type of situation, which is why we think that there should be a centralised service which has excellent training and support for a team assessing each patient.
Thanks. Colin.
In addition to that, it does come down to the training support, and that's why people need additional training support in relation to dealing with things like coercion, bias and things like that. That all comes into the training support that people require. I think we've got to also think around about, if this were to proceed, it's not only about the assessment, but it is around about when the actual time you come to administer the substance. And that we have a real concern around about that it doesn't explicitly say that it should be 2 registered practitioners who are there, because that whole thing around the huge responsibility to be put on one registered practitioner. It may be one practitioner, but the issue is with the stress on services, the stress on practitioners to be there, and all the dynamics that would come into play in relation to this. We think that something should really be thought about in relation to at that point in time, so that the assessments could be made in relation to both capacity, all the other issues, coercion. You've asked your specific question, and that would add to putting another safeguard in place, both for the patients, but also importantly for the staff who are involved.
Yeah, that's helpful. Thanks, Colin. Fiona.
Thank you. The Royal Pharmaceutical Society, we don't have a policy on this aspect of the bill, but I think from my perspective, it's you're talking about the safeguards that are going to be in place, and it's thinking about how we can make them as strong as possible. So having that opt-in opportunity where the professionals have opted in, accessing the training and the peer support that comes from that network, if you like, is all about strengthening those safeguards. And I think that's a way of supporting other professionals who may be interacting with the person to be able to raise a concern if they do feel that there's an issue and know who to contact if they do have a concern. Thank you.
Yeah, doctors do already have experience of identifying coercion, for example, where families may want us to start or stop treatment. But we do feel that coercion is an area that requires specialist training in any new service. And even with training and developing skills, we think it's not possible for doctors always to exclude coercion. So if it's later established that there is coercion, we would expect doctors to be protected from any criticism. And we do understand that there are courses in Australia training doctors on coercion, so we would hope that something similar would be developed in Scotland should the legislation change.
And Emma Harper's got a supplementary.
Just on the numbers, yeah, okay, right, thank you. Looking at the Royal College of GPs survey that was done, it looks like 13.47% responded to the survey. Is that quite a low number? And was that UK-wide GPs that responded to the survey?
It was UK-wide, and for this type of survey, that's a reasonable number. It's quite difficult to get. That was quite a high response rate, as I understand. I think 47% were against a change in the law, and 40% were for a change in the law. But I think it represents the broad range of feelings in GPs in this situation. The Royal College of GPs is currently going through a process of looking again at our view on assisted dying, and I'm not going to prejudge that. But I'm trying to represent a broad view here so that patients get a good service if democratically this goes ahead, but also doctors and our members are protected because that's the balance we're trying to get.
So, I mean, I'm asking the question only because it's 47% opposed, 40% supported a change in the law. And I'm wondering now, as, you know, legislation's being taken forward, Isle of Man, Jersey, England, maybe is it time to resurvey just to see, now that people know more about what's happening in Australia, in Canada, in Oregon, in California, other countries have taken forward this legislation, and I'm just curious as to, is it time to resurvey?
No, absolutely, and there was a process when we knew that these bills were going through different jurisdictions to actually look at the position of the Royal College GPs around the practicalities and how we support patients and our members. And that there was a group formed to actually look at that, which some of these views have been reflected on. And we're actively looking at our position now and whether we go ahead with a survey and other things like that. But I can't prejudge that because that's happening at the moment.
Okay, thanks.
Sanders Gohani.
Thank you, Convener. Just a question of interest as a practising NHS GP and chairing a working group on assisted dying. Can I just follow up, Chris, on what Emma was asking? So could you tell me the breakdown in Scotland? How many people responded and what was the breakdown?
I can't tell you off the top of my head the detail around the breakdown in Scotland, but we can let you know, presumably at a later date, that information is public and available. We don't have a problem with that.
Fantastic, thank you. It's just because the bills are different, and I think objecting to a bill in one jurisdiction wouldn't necessarily mean you object to one in a different one. It just if the bills are written badly or well.
I'm not necessarily going to comment on that because, again, it comes back to me prejudging discussions which are going on in the college at the moment. And our position is that we oppose a change in the law. We have formed a group to look at the practicalities and feedback and protect patients and our members and see what's the best way forward if this is made something that is legal.
So, Dr Provan, you could write to the committee with that breakdown of information that Sanders Gohani's asked for. Elena Whittam.
Thanks, Convener, and I just remind members of my register of interest as a member of Humanist Society Scotland. And we've already touched on this morning a little bit round about capacity, but I would like to explore that a wee bit further, if I may. And we've had some concerns to the committee in submissions about the ability of doctors and specialties out with psychiatry to undertake capacity assessments as part of the assisted dying process. Conversely, last week we did hear from the mental health panel that they did not share those concerns and argued instead that undertaking capacity assessments was a core part of medical practice. They did share with us some issues that they did have and that the bill itself turns an incapacity test into a capacity test, which is different to a lot of what we do as part of work. And also they were looking for perhaps mental illness to be removed altogether. And as we've touched on previously, looking at more senior doctors being involved in that capacity assessment. So I'm wondering if the panel could set out whether they have any concerns about the approach to assessing capacity as it's set out in the bill, and perhaps explore a wee bit more about what specialist training is perhaps needing to be undertaken. And Colin, you're looking at Dr Provan, so maybe start with we'll start with Dr.
Docs
Provan.
generally start, you know.
Thank you. So capacity is something that we come across in day-to-day practice, in general practice. We're used to assessing capacity, but it can be complex and difficult to. Practitioners can sometimes disagree. Sometimes we do ask specialist psychiatric services to help us make a decision. But we are used to doing that. We have training during our postgraduate years around that specifically. So we know the kind of criteria, but it can be very subtle. It can be time-consuming as well. It can vary over time as well. So you have to make multiple assessments, which would be important in this situation to make sure a patient still has capacity to make these decisions. Part of this keeps coming down to having time, the headspace to be able to do this with patients, home visits, spending a lot of time doing this really important work would take resources and time. We also think, therefore, it would be useful to, again, have an opt-in system where people are really specially trained to hone down their skills in this area to be able to follow this through in the process very well for the patient and have the kind of resources, time, headspace. This may not be something that you do frequently as a GP, especially in a rural area, and it would be helpful to have a central service to give consistency of service around that. Yeah, and GPs again are concerned about being caught in the middle a little bit. If they make a decision in favour on one side of a family or a situation, it could be difficult in that situation. So I think a central service would help with that.
I'm wondering if I can explore that a wee bit further. In terms of assessing capacity of an individual to determine that they're not going to proceed with treatment, so they're actually taking a decision that will absolutely end up resulting in their death. What's the difference, do you think, between being able to assess that capacity as a standalone consultant or a GP versus requiring a specialist service to assess the capacity for somebody to make the decision around about assisted dying?
The criteria really are the same around them having the ability to understand and retain information and be able to make judgments and communicate that. Sometimes it can be subtle, and if there are differences between family and patient, it's sometimes useful to have a specialist involved. Also to determine whether somebody is actually suffering from cognitive decline or dementia or something like that, when they don't already have an existing diagnosis, can help make it clear as to the status of the patient and their ability to make decisions. But it can be a subtle process which takes time and experience, and something that GPs certainly would want to have the headspace to do that, because it's not something we take lightly.
I wonder.
Yes, so I'd agree with Dr. Provan that capacity assessments is something that all doctors do in every consultation, consciously or subconsciously, and we generally presume capacity, but where we pick up that somebody may not have capacity, obviously we do an assessment. As I said earlier, assisted dying is not something that the BMA would regard as a conventional treatment. So we do think that this is different, and doing a capacity assessment is sometimes grey and ambiguous, and this is clearly an area that's going to have far greater scrutiny. So we do firmly believe that there should be specific training to any doctor who opts in to providing an assisted dying service.
Just ask one final question round about 16-year-olds. It was actually mentioned earlier round about whether 16-year-olds had the capacity to make that decision, and we allow 16-year-olds to make decisions in terms of their own healthcare in general, but I was wondering if that could be explored a little bit. I don't know if Dr. Provan, you want to start?
Sure, I think you have to make a decision on each individual 16-year-old, in the sense of go through a process of whether they have the capacity to retain, understand information, process it. It's difficult to set, a total line. It's about an individual's ability to have capacity, so it would need an individual assessment. It would be my view.
Okay. Anybody else have any thoughts on that?
Yeah, just to say that the BMA has not considered the age, as I said earlier, so the 16 to 18 difference is not something that we have considered. Thanks.
Thank you. Thanks.
Thank you. And Paul Sweeney.
Thank you, Convener, and thanks to the panel for their questions so far. Just wanted to pick up on some points that were raised in last week's committee meeting with the panel there about the seniority of doctors and specialty of doctors. Do you have a concern that there isn't sufficient specificity in the bill regarding the grade of doctors who would be undertaking these assessments, or should there be greater definition in the bill by amendment to make that clearer?
I don't think it's necessarily grade of doctor. I think I'm coming back to the fact that this is something difficult to actually undertake in an average GP practice, where it may not happen as often. I think we would support actually having a specialised service where people are actually have more experience, do this more frequently, and therefore are able to assess capacity, coercion through specialised training around that. So that's what we're calling for really in the bill, is to have a separate service where you've got, again, as I've said, doctors and their teams who are actually bought into this process, if that happens.
Do you think that that might introduce inherent bias towards provisioning of assisted dying as opposed to other options such as palliative care?
I think it's really important, and one of the things we want to emphasise is that patients are given all the options, and there is evidence of patients not knowing all the options available. So we would really want them to be, at the beginning, have all the options in front of them and have some sort of central service to give them the initial information, and then they'd be passed on to a central service to have the assessments around capacity if they wanted to go ahead with things.
But just to be clear, your preference would be for a specific service design to be specified in the bill but you aren't necessarily concerned about qualifying criteria for medical practitioners being specified in the bill. Is that correct?
No, I don't think you need a special specific qualification, but you would need a repository of central training around that these practitioners could undergo.
Okay. Does any other panel members have a view on this?
Mr Sweeney, so I think I saw the evidence that you were referring to. I think it was the psychiatrist that was indicating that he would believe that more senior psychiatrists should be involved, and I tend to support that view. The BMA's opinion, of course, is that we believe that this should be a separate specialised service, and therefore, by definition, those doctors will be highly trained in this area. So we would lean towards the more senior, highly trained doctors being involved, but it absolutely does need specified. So I think you have identified a gap.
Okay, thank you. Is there any other views on this from the panel?
No.
Okay. I just also wanted to ask about the risk of doctor shopping, which is the colloquial expression that if someone is seeking an assisted death and there's dispute with medical or clinicians, that there is sufficient scope within the bill for people to essentially seek referrals to a point where they can get what they want, regardless of the concerns raised by clinicians. And there doesn't seem to be provision for any clinician to raise concerns about safeguarding or what have you in respect to that. Is that a concern that you share, or do you have a view on that, that there should be tighter regulations around this, the nature of referrals and who does the referring? And if there's a need for a second opinion, is it the initial clinician who might be minded to grant the assisted dying provision to refer on to someone who might be in agreement, or should it be more neutral, or should it be more regulated than that?
Thanks. I think we would have concerns around doctor shopping. As I've said already, you can get differences of opinion around capacity and subtleties of these situations. And I'm going to come back to, I think, actually a separate service set up so that they have the time and resources to do this, and would act as an independent assessment. I would hopefully make that clearer. Would avoid GPs in a practice coming into conflict with a patient, their families, or each other.
So would that be the idea of having a sort of ethics panel or some sort of central register as defined in the bill? Would that be a more satisfactory structure for you? Just to be clear.
To be honest, I haven't really thought about those specifics. We're really thinking about the infrastructure around which doctors do that and who makes the capacity, coercion and eligibility assessments. So that's really all I can say in the situation.
Thank you very much. Just wonder if there's any final remarks from the panel before I conclude.
No, they're shaking their heads. Oh, sorry, Dr. Kennedy.
Mr Sweeney, if I could just add to your last question, actually, the BMA would be concerned about doctor shopping. We know that doctor shopping does happen in other aspects of healthcare. For example, people requiring occupational medicals will often shop a doctor to find a doctor who's more likely to pass them. So the phenomenon does exist, and we think that there should be open and transparent regulation, and there should be an independent body that would provide oversight and monitoring and review, and therefore reduce the likelihood and risk of doctor shopping.
That's very helpful. Thank you very much.
Thank you. I want to move on a little bit to the area of assistance and self-administration, and we've heard evidence from other jurisdictions about how medical assistance in dying has been administered, physician administered as opposed to self-administration, and different views. I appreciate the bill as it stands is about a patient themselves administering the medication. I wonder if the panel has any views on that.
I think, well, the bill clearly is looking at self-administration, and I think that comes back to the point around about there has to be absolutely clear framework what that means in relation to that. So there has to be a very, very clear legal framework for protecting patients, but protecting, again, the safeguarding for staff who are involved in this. And that does come back to the point that I made before in relation to there should be 2 authorised practitioners involved in the process and not just one. I think that should be explicit for the point of view in relation to self-administration. The other point I would make, and I don't think it's explicit enough, is when the assessment's been done in relation to the current provision that's been proposed, the ability of the patient to self-administer should be assessed at that point as well. And I think that is an omission that's not explicitly there.
Mm-hmm. Thanks. I think as it stands, the bill is about self-administration, and there may be issues around the patient not being able to self-administer because of their condition, as you've heard in other evidence, but to actually extend the bill to doctor administrating a medication to end life, that's again another step which alters the whole framework of the way we think about the bill. I think just coming to practicalities, the bill has provision, I understand, for somebody, a doctor, to be with the patient after they've self-administered. I think they would be concerned about if there are adverse effects in that situation. What is their role there as the doctor? Do they treat the adverse reaction? They're not allowed to, in a sense, end the patient's life. It's coming back to the protocols and knowing exactly what the role of that doctor is in that situation. And if you're not doing this very often in a rural community, it would be difficult to perhaps go through that process. And we want to actually have this be an experience which families can cope well with afterwards, and we have to think through exactly how we allow them to do that without any adverse events.
Can I ask the panel to what extent you feel that the bill is sufficiently clear as to the types of activities that would be regarded as assistance and therefore lawful for healthcare professionals to provide?
I think it comes back to what I was saying in relation to the absolute clarity. I think it could be much clearer in relation to self-administration and what is meant by self-administration, because self-administration, you know, can mean lots of different things. And if somebody's, for example, struggling to swallow, and you just help them slightly, that takes you beyond the line potentially. So that's why the absolute frameworks need to be really explicitly laid out, because what we don't want to leave is any ambiguity, because what we know is that in all areas of life, these things are tested when they become dispute. And what I would hate to have is where we've been through a process and something, and then there's practitioners who are actually, and I have to say, I think it won't just be medics. I would think it would be predominantly nurses who will be in that position as authorised practitioners. So I think that's why it needs to be much, much clearer, or as clear as possibly can be, so there's no ambiguity can be put in relation to administration and what is self-administration.
Sanders Gohani.
Thank you, Convener. I'd just like to touch upon a couple of topics before I come on to my main one. And given that I am a practicing GP, and Dr. Kennedy, I know you are as well. So when patients come to us and they need palliative care, in general, what's your experience with that process?
So all GPs have a lot of experience in that process. Dealing with patients who are about to enter palliative care is common, so it's a core part of our job. And I would say that most GPs and indeed patients find it a very positive process. So that's my general comment.
Do we find that when we have our patients who need palliative care, one of the things I always find very challenging is convincing patients to go along to palliative care. and to get that first meeting, because they're very scared about the whole process. And is that something that might form a bit of a barrier for some patients?
It's not something that I've experienced or my members express, but access to palliative care nurses in the community is a problem. We have far too few. And also, it's very difficult to admit patients to hospices. That's my personal experience. So the provision of palliative care in Scotland is hugely lacking. And I would say that the provision of palliative care is the main concern, and also the time that GPs and nurses who work in GP practices have to provide palliative care is very stretched. So the resourcing of palliative care would be my members' number one concern about services in Scotland, but not the actual, no difficulty really about discussing these sensitive issues. And as I kind of indicated earlier, it's probably the most rewarding part of being a doctor, and the relationship that doctors and patients have built up over many years often puts us in a great position to provide fantastic palliative care with the whole team.
Dr. Provan, if I could ask you, so a report came out recently which shows that palliative care, and I know we've got palliative care panel coming up, but that shows that palliative care is really struggling, finance-wise and with other issues. Is this an opportunity to fund palliative care better, and do you think that's important?
I think it's very important. I think patients in this situation don't necessarily know the range of options of palliative care and what is available. And as a GP, I agree, it's one of the most rewarding types of work we commonly do, but it is complex. We need more support for hospices and secondary care, palliative care, and the time to have these conversations. In a busy general practice, it's already difficult to have palliative care conversations, to have the headspace to do that. But we try and do that because it's really important, and we prioritise it as a really important area of patient care. So I think we have to be very, very careful about how we fund palliative care, and hopefully this shines a light on it. And also the impact culturally of what we feel about the end of people's lives and the value of life, so that we get the balance right in this situation.
And we've spoken a lot about palliative care nurses. And in my experience there, and I agree with Dr. Kennedy, there's not enough palliative care nurses in our community because more and more people want to die at home rather than anywhere else. So, you know, what are your thoughts around palliative care and especially when it comes to our nursing colleagues?
I think I've appeared before this committee many times talking around about our concerns around the provision of nursing in general, but I mean, our members who currently work in palliative care and do an amazing job, as I'm sure we'll all agree, have a real concern around about people's access to palliative care and palliative care nursing specifically, but all palliative care services. I think if we look across both the NHS and the independent providers, our hospices do an incredible job and are not properly funded in my view, but that's a whole different argument. So the issues around about for us and our members is around whatever happens in relation to this legislation, palliative care is underfunded. And dependent on what happens with the development of a service and how this goes forward, something should be considered around about how we support our colleagues in palliative care who, I say, provide an outstanding service, but in very challenging times, as we hear day in, day out.
Thank you. And would anyone like to comment on the question of whether within this bill we should, if somebody requests for assisted dying, that we have to talk about palliative care and the options available?
So
My members, doctors in Scotland, want to be able to discuss all the options that are available to the patients. Doctors don't want to be prohibited from raising any of the options, including non-treatment options like assisted dying. But as I said earlier, doctors don't want to be compelled to discuss assisted dying, but it would be incumbent upon all doctors to discuss all options available with patients in terms of treatment options. So that's something that we would all do in our day-to-day practice.
I'm very thoughtful to the question in relation to what it means for individual practitioners, because I would, my own personal experience in practitioners that I know would generally consider every option for a patient that was appropriate to discuss that with them. It's, I think the issues around about the protections again, around about making sure that the information is there and patients have every piece of information required to make an informed decision. Not only about if it was to go forward assisted dying, but in relation to all care that is available to them in relation to their condition that they're suffering. So I think that's incumbent on all practitioners anyway, but it's around about where you think a further safeguard could be put in relation to it.
Fiona, I'm going to turn to you and ask some specific questions about the means of assisted dying. The bill does not specify how that will happen, and I suspect that's because secondary legislation might be more appropriate given that things change in medicine. Do you think that's appropriate, or do you think they should be on the face of the bill?
I think that from a Royal Pharmaceutical Society point of view, we haven't discussed the details of the substance, the approved substance, and what that would look like. But I think it's critical that the practitioners involved in the process and being involved in handling the substance throughout its journey need to know what's within that. And we know from our discussions with colleagues in other countries that the substance itself is a closely guarded secret for probably very obvious reasons. But as part of that opt-in framework that we're suggesting, it would mean that the right people had the right information at the right time and was able to then to manage the risk around that substance throughout its pharmaceutical processes, as well as when it's being supplied to the patient. So we haven't looked at the detail of that, but we don't have a firm view about whether that detail should be within the bill. But as you say, things can change, and availability of medicines can also change, and I think that would be a better place with secondary legislation and regulation.
And given that you said it's a secret, and we sort of know what medications are used, do you think there is a sufficient evidence base for the use of the medications?
The Pharmaceutical Society hasn't looked into the detail of that, so I wouldn't be able to answer that question today. But I can follow that up with you afterwards.
That would be fantastic. There is no licensed medication for obvious reasons in the UK. Do you think that would be necessary and required prior to enactment of the bill, or do you think, given that there is off-licence use already, that might be appropriate?
The Royal Pharmaceutical Society would advocate that all medicines that are being used, the preferences that medicine with a marketing authorisation and is licensed for use would be the preferred option. That safeguards all the healthcare professionals that are supporting the use of that medicine and manages all of the aspects of risks surrounding the use of the medicine. So I think that our preference would be for a licensed product.
My final question is to the whole panel, but specifically to you, Fiona. Is it clear what should happen in the it is unlikely, but it can happen, event of complications during the assisted dying process?
We, in reviewing the detail within the bill, we think that it's really important that all potential scenarios are worked through. It needs to be clear what the role of the professionals in attendance is and when they might be able to intervene or not. So at the moment we think that there is little described within the bill that describes that risk. Whether there might be an unforeseen circumstance, an adverse event, which is unforeseen. And I think as the bill is currently drafted, it's unclear a healthcare professional would not be able to intervene in those circumstances, which has the potential to be incredibly distressing.
Just want to emphasise again, as I said earlier, and agree with Fiona around that, it needs to be very clear what the role of the practitioner and clinician is in that situation. Absolutely.
Which we would be with our colleagues.
We, the BMA, believe that it's essential that any complications are recorded, and we also believe that there should be a review of every death, and that would include time to death after administration of the substance and any complications. So definitely a mechanism for oversight and monitoring of complications.
I thank the panel for their evidence this morning, and we will now briefly suspend to change over witnesses. We now continue our scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill with a second panel of witnesses focusing on potential implications for palliative care. I welcome to the committee Amy Dalrymple, Associate Director of Policy and Public Affairs, Marie Curie Scotland, Mark Hazelwood, Chief Executive of the Scottish Partnership for Palliative Care, Dr Sarah Mills, Lecturer in Academic General Practice, University of St Andrews, and Rami Okasha, Chief Executive Officer of Children's Hospices across Scotland, known as CHAS. And we move straight to questions, and Gillian Mackay.
Thanks, Convener, and good morning to the panel. To begin with, can the witnesses provide an overview of the current state of palliative care services in Scotland? And I'll maybe start with Amy and go down the line.
Okay, thanks very much, Gillian. Good morning to the committee, and thank you for inviting us here. We're really heartened that you're spending some time looking at palliative care, because 90% of people who die in Scotland, that's the intermediate estimate, need palliative care. Not all of them get it. Best available evidence, although we've currently got research out to update this, is that 1 in 4 people miss out on the palliative care that they need. And you heard from the previous panel about the difficulties that the general practitioners have in securing the right palliative care for their patients. So the palliative care that people get in Scotland is often really, really good, but too many people miss out on that. The recent report from Marie Curie covered England and Wales only, but it reinforces the message that too many people don't get access to the palliative care they need. And I think that's really relevant to think about in the context of assisted dying, and assisted dying as a choice that people make, and the context in which they're making that choice. Palliative care is under-resourced. Many people, that's about kind of specialist palliative care, but it's important as well for the committee to remember that palliative care is not just taking place in services that are labelled palliative care. So it's not just a Marie Curie nurse or a hospice or even a specialist palliative care unit in the NHS. Much palliative care is delivered by GPs, by district nurses, in social care, and by non-specialists in hospitals as well. So palliative care happens throughout our health and social care services, because many of the people who use those services are in the last year of life. And again, it's just really important that that context of how people die now is part of what the committee is considering when they're thinking about whether or not assisted dying and how assisted dying might be introduced in Scotland.
Mark?
Yes, there's a lot of good care provided by really passionate and committed staff who go the extra mile for people who are facing very difficult circumstances. But I think that good care is often provided in spite of a system which doesn't really assign adequate priority to this phase of life. And palliative care, in the broadest sense, is a really big part of what our health and social care system does. So if you walk into any acute hospital in Scotland and look around the wards, on average 1 in 3 people will be in their last year of life. The majority of people in care homes for older people are in the last 15 years of life, and the biggest single group of people receiving care at home are frail elderly people, again, people with palliative care needs. So it's a huge part of what the system is about, but despite that, there's no explicit statutory underpinning for the timely provision of high-quality palliative care. There's no current national standards for palliative care in Scotland. There are no arrangements for reporting to ministers about the provision and quality of palliative care. There are no national programmes of investment for the improvement of palliative care. Many of the recommendations of this committee's inquiry in 2015 remain unfulfilled. There's insecurity of funding for hospices, who are major providers of specialist palliative care in Scotland. And my understanding as a member of a steering group for the forthcoming new palliative care strategy in Scotland is that the planning assumption that there is no new money to support implementation of a new strategy. And I think it's important to think about palliative care in that wider sense. People often think of hospices or specialist provision, which is very important. But palliative care is something which is embedded throughout our care system. We heard in the previous session how fundamental providing palliative care is to general practitioners. The backbone of palliative care in the community is district nurses. It's our care homes and our care at home services. And you as a committee will have heard, I suppose, what might be described as the frail condition of our health and social care services. And so I think it would be fair to say that that frailty applies to much of general palliative care in Scotland as well, where we have overstretched teams, sometimes struggling to be able to provide the care that they would wish for the people they're trying to look after. Thank you.
Thank you. And certainly I would echo that the provision of palliative care is very much primary palliative care for the majority of people, so care that is being delivered through general practice, through district nurses in the community, as opposed to specialist big C palliative care delivered in hospices and through specialist palliative care teams. The majority of people who die don't access specialist palliative care services but have care provided in the community. That care is very overstretched. We've seen since COVID a sustained 35% increase in community deaths. There hasn't been a 35% increase in workforce in the community. There hasn't been a 35% increase in capacity. We have absorbed beyond what we can safely absorb and can continue to work. The evidence that we largely have for palliative care in the community and for primary palliative care is largely pre-COVID. So we're still getting emerging evidence for what the impact of COVID has had on the provision of palliative care. And certainly, as I say, we're stretched in terms of our provision. The palliative care, when everything works, when the planets align, when you can provide the services to the patients, is excellent, but the services are not adequate to meet to meet the need.
Thanks very much. I'm from Children's Hospices across Scotland, and we work with children and young people from the age of 0 to 21. And so I would say that the position around children's palliative care is a little bit more different because the population group is much smaller than compared with adult palliative care services. So in Scotland, about 3 children a week die from a life-shortening condition in Scotland. And the majority, or most of those, would be under the age of 5. So many of those will be children who are babies. And so the position, I suppose, is that for young persons and people over the age of 16, which is, of course, what you are thinking about today, then often the care that is provided to those people will be from a specialist disease-directed team, usually operating out of an acute hospital, not always. And what we see is that the role of palliative care for children and young people takes on some differences from the role of palliative care for adults. So often it will start much earlier. So palliative care should begin at the point of diagnosis, not at the point of approaching death. And that means that palliative care can often be provided for many, many years. And indeed, in CHAS, we see with the increasing medical advance, lots of young people who had been thought to die in childhood actually now transitioning and living into adulthood. And so the patterns of disease are rarer, more complex, and affect a smaller population. So in Scotland, CHAS works right across Scotland in Scotland's 2 children's hospices, but also teams in every local authority area in Scotland supporting families at home. And in partnership with the NHS, we have specialist palliative care teams for children in each of the 3 children's hospitals in Scotland.
Great, thank you. The variability in palliative care provision and high levels of emergency admissions in the last 6 months of life highlight the fact that there are very significant gaps in end-of-life care. Does the panel believe that addressing these issues should be a prerequisite or a parallel commitment to the advancement of assisted dying legislation? I'll maybe start at the other end and come this way this time.
I think one of the things that I find concerning is the idea that for older adults in particular, there is a choice between assisted dying and palliative care. Palliative care should begin early. It should begin whilst active treatment is being provided, and it should support a holistic approach to helping people to live well. In relation to children and young people, I would say that is a more established approach, that palliative care begins at an earlier stage. So I would caution you as parliamentarians not to consider that this is a choice that people have between palliative care and assisted dying. If that were introduced, the evidence that Amy has led about the need for palliative care across a wide range of people is, I think, an indication in relation to that. I think there are important questions about access, equity of funding, and ensuring that the appropriate palliative care services are there. But even if this bill were not to proceed and parliamentarians were not to support it, the need for palliative care would remain. And even if parliamentarians did support it and it became law, there would be many people who may wish to access assisted dying, but for whom palliative care is necessary and can provide significant relief and support for many, many years prior to death.
So certainly, I absolutely agree with what you said in terms of care in the last year of life. We know that in Scotland, 95% of people who are in their last year of life will have contact with A&E, GP out of hours, or the Scottish Ambulance Service. And that's not because their needs are being met and they're comfortable. That's because they're having acute needs that are not being met by the care that they have at that moment in time. If you're saying that 95% of people in a country have acute unmet needs during their dying phase, we're not doing enough anticipatory care planning to take that step back and make sure that people have got a plan, have got medication in place, have got the security to know that if something goes wrong, there is help for them. And I think that until you can adequately say we have delivered excellent care to everybody who needed it in Scotland, and then there is a small percentage of people who would still choose, in spite of the fact that their care needs are being met, that they have dignity, that they have a pain-free approach to the end of life, that whether they choose assisted suicide at that point, it's a legitimate choice. But at the minute, we don't have a legitimate choice because we haven't optimised the care that we are already able to give and that's already legal to give. And I think that until that's done, choosing to change the law to allow for people to have an assisted death is a false choice. It would be akin to saying, my morning commute is terrible because it takes me ages to get there, so what I need is a helicopter. No, what I need is buses or potholes to be fixed in the road. I need the basics to be done and the basics to be gotten right before we have a discussion about whether or not a helicopter would be a very good choice for me. We're not getting the basics right for everybody, and until we do that, we shouldn't be in a position to consider this.
Yes, I'd just briefly like to preface what I've got to say, in fact, preface everything else that I say in terms just to explain SPPC's position as an organisation. So assisted dying raises obviously issues of a moral, personal and ethical nature, and those are issues upon which many of our member organisations can't take a specific position. So, for example, our membership includes all the health boards, all the IJBs, a whole range of different charities, the hospices, professional associations. So SPPC therefore doesn't adopt a position in principle, either in support or in opposition to a change in the law. But we do aim to critically review and present a view on the specific provisions of the proposed bill, such that if the bill is passed, then harms, particularly to vulnerable people and to the practice and provision of palliative care, are minimised. So that's just by way of context. So in our submission to the committee, SPPC raises the idea of contextual safeguards. So there's a lot in the bill about procedural safeguards, but people make decisions within a wider context, and that influences perhaps the choices that they will make. And in our submission, we're very clear that good, timely access to high-quality care is an important safeguard. I would echo what colleagues have said. I mean, palliative care, you've heard about the deficiencies, and I've been in this room talking about the deficiencies when there was a previous bill, and the one thing that everyone in this debate agrees is that palliative care needs to be improved. So palliative care needs to have more investment and to be assigned a greater priority, regardless of the fate of this particular piece of legislation. But certainly in our submission, it's our view that if people are considering the future and making choices, it is inevitable that some of them will be influenced by their perception or the reality of the care and support which they and their carers may need to face the time coming ahead. So we don't think that you can separate out the context, and palliative care is a really important part of the context that people are dealing with when they're approaching the end of life.
I should also at this point make the point that Marie Curie takes a neutral position on assisted dying, campaigns neither for nor against the change in the law. Our concerns are around equity and around the best possible end-of-life experience for everyone in Scotland, no matter who you are, where you are, what your diagnosis is, or how old you are. And I think all of those things are important because they all of those factors do currently have an impact on how you experience the end of your life. We released a report last week which says that 10,400 people who die in Scotland are dying in poverty now each year. And that's an increase from the last time we did this study, from 2019, of nearly 2,000 people. That is going to have an impact on how you experience your last years, months, days, weeks of life. Your social circumstances, your economic circumstances are all going to have that impact. And then also there is the care and support that you can access. Is it really tolerable to any of us that somebody might choose an assisted death because they haven't been able to access the palliative care or the social care that they need that would make them comfortable? And that is a question that we all, whether we're sitting this side of the table as you know, academics and campaigners and people trying to develop policy solutions, or as practitioners, whether we're sitting on your side of the table as MSPs, should be really, I suppose, trying to answer about that context in which people die. It's hugely important. And the question around assisted dying is whether and how it would or can improve people's experience of end of life. But for most people, assisted dying will not be relevant to their experience of the end of their life. Experience from, you know, kind of evidence from other countries shows us that a really small proportion of people choose an assisted death. So for most people who die in Scotland, it's these other factors, including palliative care, both specialist palliative care and generalist palliative care, and the equity of access to that care, so that your choice is not being dictated to because you live in a rural area and therefore it's harder for you to you know, access the specialist care that you might need, or you are dying in poverty and therefore your circumstances make it difficult for you to access the specialist palliative care you need, or you have trauma in your background and therefore don't trust the services and find it difficult to access the services that might help you have a better end of life. That shouldn't be something that is making people want to choose an assisted death, and that is what we ought to be focusing on improving.
Thanks, Convener.
Brian Whittle.
Thank you, Convener. Good morning to the panel. I would just kind of take that theme a little bit further and look at maybe the potential for this legislation and the impact it may have on palliative care. And we have tried to look at this before. I don't want to mention to the rest of the panel, but I feel I have to, the evidence session when witnesses from Canada, where they came from diametrically opposite positions on this one. I think saying it's a split in opinion is an underestimation of that particular session. But one of the witnesses was claiming that palliative care resource had improved and palliative care had improved following the legislation, where the other claimed the complete opposite. In fact, Amy, one of the things they talked about was that the impact of deprivation on the access to palliative care. So if I could ask, you know, are there concerns around this particular bill having a detrimental impact on palliative care, or potentially the opposite? I'll come to you first, Amy, since you raised the issue in the first place.
Thanks, Brian. Thanks for raising that. Assisted dying is not palliative care. They are two different things. And we can, the government can, we as a society and as a system can choose to improve or not improve palliative care, whatever happens to this bill. So the way that we would see it, if this bill passes or if this bill does not pass, the choice can be made by all of us and the government to improve and better resource palliative care. Or you cannot make that choice and palliative care continues to struggle with resource, and we continue to decide that people who are dying should have their care subsidised by charitable donations in a way that the care for other people who might get better or should not be subsidised, for example. So that's a choice that can be made that doesn't necessarily need to be dependent on whether this bill passes or not.
Okay, as I'm going to go along the line with this particular one, can I add into that though? Given what the initial question was, is there any evidence to suggest there is internationally where this has been introduced? Is there any evidence to suggest, or have you looked at any evidence to suggest that palliative care is impacted one way or the other? I'll come to you, Mark.
I have looked at some of the evidence, and I would say that I think I'm very wary of drawing kind of definitive and firm conclusions from these international comparisons, because there are very different social, cultural, political, historic, institutional settings. There's also the problem of different definitions, so comparing apples with oranges when you're trying to compare the data, and also in many jurisdictions the record of completion of data in this area is not so great either. But when the consultation proposal for this bill came out, there was quite a lot in there about resourcing in other countries. And I did some comparisons and some calculations to look at what might be expected in Scotland, adjusted for population, given what that consultation document said about funding increases in other countries. So the state of Victoria was mentioned, where there was 72 million Australian dollars allocated for palliative care. And by my calculations, these are 2021, it's a little bit out of date now, but that would equate to £33 million in Scotland. And then in Canada, there was a government commitment to providing $6 billion over 10 years to improve palliative care. And that would equate to £512 million in Scotland over a 10-year period, so £50 million a year. So I don't think there's anything, there's no sort of no kind of logical necessity that means that because there's a change in the law about assisted dying, therefore there will be funding of palliative care. And I mean, you'll know the state of health and social care finances in Scotland, so you may take a view on whether there's likely to be a government allocation of £512 million to improve palliative care in Scotland. I would love it if there were, and we could spend every last penny very well. And I suppose the other thing that occurred to me on this is that we probably don't really need to speculate on what conclusions we could draw from the international evidence, because the real answer to this lies with Scottish Government and Scottish ministers, who might be able to give an indication of what investment might be forthcoming. But as we've all said before, there needs to be investment in palliative care in Scotland, regardless of what happens with this bill.
As we're moving on, I'm going to keep adding layers on.
No, and I absolutely echo and support everything that's been said. Palliative care is separate to this and should be funded and resourced, whatever the decision is taken with regards to this bill. In terms of your specific question for international evidence, I am more familiar with the Canadian system. I was born in Canada and came over here when I was 20. And my understanding which would apparently agree with half your experts, is that funding has gone down in Canada for palliative care since the introduction of assisted dying. I think that funding is fickle and flows with political will, and I think wherever there was seen as an alternative to any medical specialty, it would follow that there may be a reduction in funding for research and for investment within that specialty. And if assisted dying is seen as an alternative to palliative care as opposed to a separate decision stream, I think it would be a risk that that investment in palliative care, both research and clinical delivery, would be affected.
A cohort of people you look after.
Absolutely. I mean, I think the international evidence is contested, and I think you've heard that. I suppose what I would say to you as parliamentarians, though, is to consider the bill in front of you and make the decisions that you intend to make and the scrutiny you apply based on the contents of the bill, rather than what might happen in other jurisdictions or what you think about where funding decisions might flow. There is a very strong case for increasing palliative care. It actually has a relieving effect on other parts of the healthcare system in itself. So there's an economic case. I would say there's a moral case as well in relation to investing in palliative care. In Chaz, like other organisations, we haven't taken a moral position for or against assisted dying, but we have significant concerns about the detail of the bill in front of you. So I would encourage you to make sure that your deliberation and scrutiny is focused on the content of the bill rather than any issues around funding.
Thank you.
Lena Wilson.
I would like to speak about palliative care as an adjunct, as assisted dying as an adjunct to palliative care. So we've heard quite clearly that we have to look at them as two separate things, and I think that that's absolutely right. We've had written submissions and oral evidence that says, that palliative care can be complemented by assisted dying as an alternative, and people have stressed that there's a therapeutic value of having a choice of an assisted death and how it can remove an element of suffering not addressed by palliative care, even if it's ultimately not exercised. Conversely, we have heard that the two are not compatible and that assisted dying would divert resources away from palliative care and erode its quality and availability. So I would like to explore that a little bit. And the first question I have is round about whether witnesses recognise the potential therapeutic value accessing assisted dying can have for individuals approaching the end of life, and for those individuals especially who the best palliative care would perhaps not be enough to relieve their suffering. And I think I'll start with Amy and work across that way, please.
It's not something that Marie Curie has researched or has taken a position on. Although we think that palliative care can be done better, and even if it was done to the best, to its full potential, for everyone, as perfect a palliative care system as you could get, I also wouldn't want to overclaim for the fact that that every single individual would have a death, would have a good death, what you might call a good death, if they had extremely good palliative care. However, it would be a very, very small minority of people for whom that would not be adequate. So if that is the rationale behind supporting assisted dying, it should just be recognised that it is for a very small minority of people. But I wouldn't want to comment on the specifics of your question. I can't do it from that because we haven't done the work to support any position on that.
Mark?
Yeah, I think in our submission we've described the quite common experience of specialist practitioners in palliative care when somebody, perhaps who's just received a diagnosis or a bad news about the worsening of their condition, who may come and express a wish to shorten their life. It's not an uncommon thing, certainly in specialist palliative care, and I'm sure more widely. And obviously a big part of what palliative care does is to explore to surface, to explore, and to seek to understand the causes of those feelings, because there may be many different causes and different feelings leading to a person expressing that view. So people are often scared about the end of life. They may have heard things which lead them to be very alarmed about what may happen towards the end of their life. They might have all sorts of practical concerns about their finances, about their loved ones, what will happen, and concerns about, maybe they feel that they won't get the support they require. So as you can imagine, obviously there's a huge amount going on inside people's heads in those sorts of profoundly difficult circumstances. So obviously at the moment the response of our system to that expression of suffering is to seek to understand and to be able to address the causes of suffering. And it's one of the reasons that many practitioners of palliative care have some concerns about the bill, is that they have a very common experience of somebody coming to them with expressing a desire to shorten their lives, but following discussions to understand the causes of those sufferings and measures to address that suffering, that people then change that view and go on to live a good quality of life for extended periods in the context of them living with an incurable condition which will lead to the end of their life. So you can imagine from the practitioner's point of view the importance which they assign to listening to that expression of suffering, which expresses itself perhaps in this desire to shorten life, but to get into conversations about which underlies that. So that, I say, that's a major cause of the concerns that many practitioners have around the bill, whether they have a definitive position for or against. I think I would add to that, though, that some people do have an enduring wish to hasten their death, and obviously such individuals have that wish needs to be respected, and there's a need and a right for that wish to be respected, affirmed, and valued, and that applies regardless of what the law what the law does or doesn't enable. So that's quite a long answer, but certainly there's a very big therapeutic value in unpacking the causes of people's suffering, which may lead them to give expression to a wish to hasten their death. And I wouldn't, there are causes of suffering which are not all suffering can be ameliorated even with the very best, the very, very best palliative care, which not everyone gets access to.
Going to ask you if you can even lengthen your answer a little bit for me. I just want to explore that therapeutic effect that access to assisted dying is reportedly have for some people who may not eventually actually exercise their right to it, but who report that unpacking those really difficult conversations with palliative care specialists and exploring all those options and availing themselves of that is actually the thing that allows them to live as best as they can for their remaining time, even though they don't exercise that right at the end.
Well, I think that's two different things there, because if you're talking about a palliative care intervention, that's a distinct thing from having support to end one's life, which is obviously what the assisted dying bill is proposing. So assisted dying isn't part of palliative care. The WHO definition of palliative care is very explicit, that palliative care doesn't involve the hastening of death. So, I mean, this is one of the things, talking about impacts on palliative care, this is one of the things which the bill, and in fact already the debate surrounding the bill does, which is there's quite a lot of confusion about what the term assisted dying means, and some polling evidence that the public believe that it encompasses things which, such as the right to refuse treatment that they don't want, or the withdrawal of life-sustaining treatment, and also a smaller percentage of people who believe it even encompasses things such as hospice care. And in our submission to the proposal for legislation, we presented a case that more explicit language should be used to describe the bill, because assisted dying is not well understood, and in a plain English sense could be felt to describe all sorts of things which are already palliative care practice. So and I think there's more than a kind of esoteric point, because if you are a practitioner engaged in having conversations with somebody in these circumstances, there's already a very complex and nuanced conversation, and one of the impacts is that there would be a need to try and make sure that people are talking about the same thing at the same time, which will add to another challenge in whatever is already a kind of complicated and tricky conversation to have. Don't know if I've answered your point.
I think that's quite helpful, and the questions that I'm trying to get at are around about assisted dying being an adjunct to palliative care, two separate systems, but perhaps how, if this bill was to become law, we could perhaps see an integrated pathway that the two systems would have to interact with each other and how they can mutually benefit the patient. So I think in the interest of time, I'll need to move on and let Dr. Mills and perhaps Rami answer as well. Dr. Mills.
Thank you. I mean, it's a very complicated situation. I will say you'll see from my written submission that I put that I'm against the bill. That is my position on the bill, but not necessarily on assisted dying, which I think is very complicated, very nuanced, and something that needs to be explored in greater detail. I would say in terms of therapeutic benefits for patients, knowing that they could end their life at a time of their choosing, as I understand it, there's no research to support that. That's not to be said that it doesn't exist. That's to say that I'm not aware of the research supporting that. But it would certainly be something that should be looked at if this was to come into legislation. I do certainly think that there's therapeutic benefit in being able to say to patients that you will relieve their suffering, or that you will, for them to know what the plan is, and for there to be a plan that is acceptable to them, and a plan that does relieve suffering, does relieve distress, where they know what to do if things are going wrong, where they know who they call, who their family are going to call if things go very wrong. And I think at the minute, the current state of palliative care is that not everybody has that. You know, we've heard from maybe 1 in 4 people missing out on palliative care who could benefit from it. We know through my research and the research of others that 20% of patients don't access even sort of emergency or unscheduled care services at different times when they could possibly benefit from that. We know that in other areas in the UK where they have gold standard palliative care services that are opt-in services as an adjunct to primary palliative care, that only about 50% of patients who die in those areas access those services. So we're seeing that there's a huge gap in how care is being delivered. I think a lot of the distress that comes around dying is from people not knowing what to do when things go wrong, not knowing what's going to happen, not knowing if they'll be comfortable. And a lot of the fear and anxiety around death we can alleviate with good quality palliative care, but we're not able to do that for everybody who needs it at this current moment in time, which I think, one of my serious concerns is introducing this legislation in the current NHS and the current crisis in both health and social care, because it may be actually that a lot of the distress could be around whether you'll have carers or whether they'll be there, whether they'll be people that you know, whether you'll be able to have care in home. I certainly know for practices where they have access to community hospitals or to palliative care beds, a lot of patients find relief in the knowledge that they could have that level of service or that level of input should they require it. And certainly relieving suffering in that way is I think, a huge priority, something that we need to do more of.
Thank you.
I think we fear death. Society fears death, and we don't talk about death enough. I think it is the case that in respect of children and young people, most children and young people who, including young adults who die, are supported to do so peacefully, with dignity and with much love and compassion. I think what I would say to you, though, is that there is no regime, thinking about both children and adults, no regime which either includes or does not include assisted dying, which can eliminate all suffering. And it would be wrong to think that there is. The question for you as parliamentarians is where you think the balance of risk lies based on what you see in society and what you see in the bill. And to Dr Mills' point, it is perfectly plausible to say that you are in favour of assisted dying but find flaws in the bill. And certainly some of the things that are in the bill I think would require much further attention to be able to allow you to do that. In relation to the efficacy of children's palliative care, it is documented well in the literature that there are symptom management approaches which are very, very effective at relieving even the most complex of pain. There is a need for more research into symptom management, particularly in relation to rare conditions. But what I would encourage you as parliamentarians to do is to focus on the specifics of the proposal that you are scrutinising, which includes a number of areas, including a very broad and I would argue flawed definition, which would encompass many more people than you might expect. So I would say that my encouragement to you is to think not just about the abstract, but the specifics of the bill that you are providing scrutiny to.
Convener?
Emma Harper.
Thanks, Convener. Just before I come to my questions about conscientious objection, it's just to go back to you, Rami, about what do you mean about the definitions in the bill that would open it up to be wider? Are you talking about the definition of what is a terminal illness?
Harper, I would agree. I think the proposed definition is imprecise, and I think clarity on the face of the bill is so important. If I might give you an example of this, the terms advanced and progressive have no consensual understanding. There is no agreed definition of what those things are. So we might take a young person, for example, who has an advanced and progressive condition that will mean that inevitably their life will be short and they will live into adulthood and have a number of years of life left to live, but would fall within the definition of this bill. So I'm thinking of a number of progressive conditions which can present as being certainly arguably advanced at a stage which would be many, many years before death. And so I would encourage you to apply more scrutiny to that particular definition in the bill.
Okay. Okay, so Sarah.
Coming in on that as well, it also fails to account for multimorbidity. So we know that by 2040, about 40% of people who are dying will be dying from multimorbidity conditions as opposed to necessarily one single disease that's causing death. So it talks about an advanced condition, but it doesn't say what happens for your 90-year-old lady who has, failing kidneys and a little bit of heart failure, a little bit of respiratory failure, and has a fall as well. And we're seeing a lot of complexity around end-of-life care that isn't reflected in the definition.
Go ahead.
Sorry, I was going to say a few other things, but I can see other hands up, so I don't know who.
Because we still have quite a lot to get through.
Very happy to. I mean, I think one of the other areas of concern, Ms Harper, that I have around the definition is the assessment of that for young people and for children who are transitioning into early adulthood. Often the conditions that they present with are rare, are complex, are not often seen in primary practice, will be under the treatment of a consultant in a hospital. And so for us, I think there requires to be much more consideration about the level of expertise that is involved in making assessments around these judgments in relation to children and young people.
Okay. Okay. I'll go on to my conscientious objection.
If you don't mind, and if we can keep questions concise and to the point, and if panel members can do similar, I would be very grateful.
Okay, thanks. Thanks, Convener. So I'm a nurse, and I have been a nurse for more than 30-odd years. I'm interested in issues around conscientious objection. So is there enough clarity as to which staff and activities would be covered by the conscientious objection clause in the bill?
Very, very happy to comment on that. I mean, I think in short, the answer is no. The detail is not sufficient. I found the evidence that you heard from Mary Neal previously very compelling on this point. I'm very pleased that there is a policy intent to allow conscientious objection, but the wording on the bill is not sufficient to deliver the intent that's set out in the policy memorandum.
Okay, and I know Mark wants to come in, so you, I suppose, prefer further provisions in the bill to help protect professionals in terms of if this bill progresses and becomes an act?
Yeah, absolutely. At the moment, the words on the bill, on the face of the bill, do not give rise to the policy intent to give certainty about conscientious objection.
Okay, all right. I think Mark wanted
Yeah,
to...
so there's not sufficient clarity in the bill on the scope of the conscientious objection. You'll have heard, obviously, in your session last week about a concern that the bill can be passed, but without any meaningful conscientious objection clause because of the reserved powers issues. And as an organisation, there are other reasons for objection which may not be conscientious. So we have said that there needs to be the ability for professionals to not to have to do this, regardless of whether that's grounded in a conscientious objection or not. And lastly, the conscientious objection, for example, in the Abortion Act, which I think this bill draws on to some extent, is quite narrowly drawn. So we would wish to see the flexibility in the bill such that people who are perhaps quite peripherally involved in the process of, potentially involved in the process of assisted dying, could also have the ability not to participate. I'm thinking there a bit, there's, well, we'll probably come on to this. I'll stop there because you did ask us to be brief.
I would also agree that there's not sufficient clarity in the conscientious objection, but I think that throughout the bill lacks clarity that would allow us to be very clear about how this service is going to be delivered, and the conscientious objection clause needs to follow from that. So, for example, if this is a service that's being delivered through general practice, what happens if you're the single-handed GP in Orkney and you want to make a conscientious objection to it? Who takes care of your patients? I think that it needs to have a lot more specificity all the way through the bill in order for the conscientious objection to have meaning and for there to be a legitimate backup plan for patients for whom their only medical contact may be someone who conscientiously or non-conscientiously objects.
Okay. That's it. Thanks.
Thank you. Carol Mockin.
Thank you, Convener. My questions really are, we've heard from different countries that have taken part in our evidence that there's different approaches to doctors' responsibility to discuss assisted dying with their patients. And a number of people who have responded to the consultations, particularly those interested in the law around this, are asking, is there a duty on doctors to raise this if the bill was passed? So I would really be interested in your view on that as the bill stands and your opinion on that option and the implications for staff in that regard. So, yeah.
I think the bill, as it stands on my reading of it, does not indicate whether anybody would be obligated or not to discuss assisted dying with a patient proactively or reactively. So I don't think there's anything in the bill about this at the moment. What I would say is that were an obligation to be introduced or the lack of obligation or whatever, were this to be mentioned and introduced to the bill and that clarity to be provided, we would say that, kind of, and bearing in mind the Montgomery ruling in Scotland, that the other treatment options ought to be discussed as well. And that leads very clearly back to the point we were discussing earlier about the adequacy of provision of palliative care in particular, and social care as well, I would say, as being relevant to people who would be eligible for an assisted death and any other forms of care and support, because it would be wrong to be raising those issues and discussing those as options for care and treatment if they were not actually available and if assisted dying was. So you've got to make sure that the treatment options you are discussing with people are available, and that ought to be a genuine choice and not just be driven by your circumstances there, which are dictated by a lack of resource. I hope that is helpful towards answering your question.
Yeah, thank you. Does anyone else have a view on this?
Yes, I think obviously the bill is silent on this, and the concern that we've raised is that the Montgomery case may constitute a common law duty for doctors to raise the topic of assisted dying. So what we've done in our submission is just to raise some of the kind of potential difficulties and complications around that. So for a doctor proactively to raise assisted dying, so potential for that to shut down exploration of other issues and problems. I think also the potential for the raising of the topic to send very negative messages to the patient, for example, that their life isn't valued, that other measures might be deemed inadequate, and that there's not hope. And what we do know from extensive research is that how people with advanced illness feel about themselves and their lives is quite strongly impacted by the way in which they feel they are viewed by health and social care professionals. And it's really in that context that we raise that concern. What message does it send to a person in a very vulnerable situation that somebody might be perceived as suggesting this as an option for them?
Thank you. I think that it's an important point to consider. I think that it is very difficult to make it a requirement for doctors to raise assisted dying with patients. As I've said, the identification of people who are in the last year of life is imprecise and suboptimal as is. So you could be in a position where you've introduced a requirement for a doctor to discuss assisted dying with a patient they may not have realised is dying, or where the patient themselves doesn't realise that they're dying, or where the doctor may be in a position where they're discussing with family members when the patient is very much at the end of life, and the family members say, well, why didn't you bring up assisted dying before they were in their very last days and weeks? And we know from a number of pieces of research that actually average identification of death is very much in last months, if not last weeks of life, rather than significantly before that. The timelines as set out in this bill seem to assume that we've all got a knowledge of who's dying and what sort of timeline that they will have, and that this is a very predictable thing that we can take large steps back for. The identification of people who would be expected to be within their last year of life is hugely complicated and nuanced, and the subject of ongoing research in a number of places. There's also the fact that you cannot raise something in a medical consultation in a way that is neutral. If a doctor says to you, have you thought of quitting smoking? Well, that's not a neutral, have you thought of it? Have you thought of, most of what we bring up in a consultation, patients take it to mean that we're in favour of it, whether or not we try to present it in a way that is neutral. Thinking at the minute of, if we were to envision a future in which there was an assisted dying provision parallel running to provision of palliative care, similar to what we see now with NHS and private work. If I say to a patient who is waiting knee surgery, have you thought of going privately? I'm saying to them, I don't think the NHS can provide the care that you need along the timelines that you need, and I think you should explore your other options. I think that saying to a patient who has a terminal illness, have you thought about assisting dying, would have that same sort of subtextual context, and I think it would be very challenging But I think that for purposes of the difficulty in identifying patients and then the weightedness of bringing it up in a consultation, it's not possible to tell doctors that they have a duty to do this.
I think in relation to children and young people, I cannot envisage a circumstance where it would be ethical to proactively raise this issue with a family or a young person. And I suppose I say that for three reasons. I say that because of the very privileged relationship that healthcare professionals have with children and young people and their families who they may have known over a considerable period of time prior to their age of 16. I say that in relation to the broader issues around the appropriateness of the age threshold, which we may come on to. And I say that because of the difficulty of prognosis in relation to disease which presents in young people, where it is often extremely difficult to be able to understand what a prognosis may look like, where we are dealing with very rare conditions which may not have been seen by an individual clinician previously in Scotland. So I think that would be an area that the committee would need to reflect very, very carefully on.
Could I have a brief supplemental on that? I would also say that the current state of the NHS is that a lot of secondary care wait lists are over a year long now, and we're frequently in a position in primary care where you're looking at somebody who you believe is very clearly dying, but who does not yet have a diagnosis for the condition that they're dying from. And I think that putting primary care practitioners in a position where they don't have a diagnosis for a patient that they have referred to secondary care because of the state of the NHS, but then requiring that that GP to have a discussion with an as yet undiagnosed patient about assisted dying from a condition they have yet to be diagnosed from is unfair. And I think that that circumstance would not be as unique as you might hope it would be.
Thank you, Convener. That answers my questions.
Thank you.
Thank you, Convener, and thanks to the members of the panel so far for their contributions. Just want to come on to the definition of terminal illness. Clause 2 of the bill is currently drafted on the bill. Defines someone as terminally ill if they have an advanced and progressive disease, illness or condition from which they are unable to recover, and that can be reasonably expected to cause their premature death. A number of concerns have been raised by stakeholders about the breadth of this definition and the potential for it to include a wide range of long-term conditions, and some have proposed that the inclusion of a prognostic timescale, such as the 6 months definition in the UK bill, or a wider definition of 12 months, would be an effective means of narrowing that definition. On the other hand, others have raised concerns that the definition is too narrow and could discriminate against people experiencing other non-terminal conditions that nonetheless bring unbearable suffering. So I'd just like to ask the members of the panel, from a clinical perspective, what types of conditions do you think would be covered by the definition of terminal illness in the bill at Clause 2 as currently stands, and what would not be covered? I don't know if anyone has any initial desire to respond.
I'm not a clinical person. We've got a clinician on the panel who'll be able to give you kind of more technical views on this. But the terms in the key terms in the definition, such as advanced and progressive and premature mortality, aren't terms which are precise or have agreed definitions. And so the bill, that definition doesn't deliver the sort of clearly defined, quite narrow cohort, which seems to be the policy intent contained within the policy memorandum. And I think the result of that is that there will be variation in interpretation, confusion on the part of the public and practitioners about who may be eligible, and inconsistency. So that's a real concern in terms of what's in the body of the bill. Section 23.2 gives the powers to ministers to make guidance on assessing eligibility. And And I think when you start to move from quite a brief definition in the bill to starting to think about, okay, well, how will we assess and implement this in practice? That's the point at which you come up against the complexities and difficulties of trying to come up with something which is coherent and tidy around the edges. And I think it becomes very difficult. And I have personal experience of that. I was asked by the Chief Medical Officer's office to chair a group which was trying to put together guidance to implement as part of the Social Security Scotland establishment the brief legal definition in that bill of terminal illness. And what we found in that piece of work was it was really very difficult to take those vague terms, advanced and progressive and premature mortality, those sorts of terms, and apply them very precisely in practice. And in that piece of work, we were keen to ensure kind of broaden eligibility to rapid, fast-track access to terminal illness benefits for people approaching the end of life. But it does mean that whatever's on the face of the bill, the scope of who may be eligible for assisted dying could vary quite a lot according to what the Scottish ministers develop in terms of assessment. And I also think that potentially leaves that definition quite vulnerable to scope creep as well, because it's not a clear definition and it therefore is inherently contestable. Thank you.
Thanks very much. Would you have a preference in terms of amendment to Section 2 of the bill?
I'm afraid I don't have a clear and simple conclusion to this. And there's a real difficulty. I know, obviously, south of the border, and I think in previous possibly bills at this Parliament, there has been the inclusion of a prognostic timeframe. But that's problematic, and you'll have heard evidence already, I expect, about the difficulties which clinicians have in providing a clear prognosis with any degree of confidence. We don't have a view on whether that would be better or worse than what's in the bill, because really we're commenting on what the provisions of the bill before us are. But I do know that there's real difficulties in being able to provide that sort of prognostic accuracy.
Thank you very much, Mr. Hazelwood. Dr. Mills?
Thank you. I think the definition is very vague. Certainly premature mortality, well, does that mean people who die before the average age of the population? So anyone dying after 74 would not be considered to be dying prematurely and therefore would not fall in the scope of it. It also fails to consider multimorbidity as a source for, and as an increasing source for why people are dying. So dying from more than one condition as opposed to one single condition. And in terms of the discussion around timeframes, I agree that it's tempting to put a time frame in because it would narrow the definition, because as things stand, I think quite a lot of my patients would fit within that definition, who are living very well with advanced diabetes or other advanced conditions that could reasonably be seen to hasten their death. It also doesn't cover for patients who have a single catastrophic incident like a stroke or being hit by a bus, because that's not progressive. It's not expected to necessarily happen again. So I think the definition itself needs to be looked at, and I think that that is beyond the expertise that you have in the room at the minute, or that you've heard from. But I would say in terms of doctors' ability to decide whether somebody is in their last 6 months or their last year of life is very imprecise. My research focus is very much the last year of life, and determining if somebody is in that or not is hugely challenging and incredibly complicated. I was smiling earlier because I'm doing on-call Christmas Eve this year, and the patient I told would not have a second Christmas says he will phone me at 5 minutes to 6 to tell me I was wrong. So. Well,
I think you've highlighted very clearly the challenges with prognostic forecasting, given the complexity of life, really. just wondered, just to build on your point about, say a catastrophic neurological event, are there specific conditions you think should be more clearly defined in the bill, or indeed things that should be excluded specifically, such as diabetes, for example?
I think that within the scope of this room and within the scope of the experience that's available, you cannot ask us to pin down a definition that will work for this bill. I think it's one of the things that is a huge risk for this area, is finding a definition that works for the people for whom assisted dying is may well be the preferable choice, versus that doesn't encompass everyone. So I would say in my career, which is 15 years, I've come across perhaps 3 people for whom I felt that it was absolutely the right thing and that there was nothing else that could be done medically. But I would see 3 people a day who would fit the definition that you have in this bill. And I think that the legislation that would allow for that very small number of people for whom even the best palliative care cannot adequately control their symptoms, but would not raise the question of assisted dying for the vulnerable, the elderly, people from protected and minoritized backgrounds, people from inclusion health groups who would feel huge amounts of psychological and social pressure to proceed with assisted dying for financial reasons, for pressure reasons, for even whether or not there's direct coercion by other people, the pressure being economically non-contributing and perhaps needing extended levels of care, and the extent of the impact on family and friends is something that people at the end of life feel very keenly. And I think the definition as written does nothing to protect those vulnerable people.
Just also wanted to ask about your specific view regarding the prognostic timescale. Would you want something like that as the equivalent of the UK Bill 6-month definition? Is that something you'd be content with, or?
So it would be ideal if we lived in a world where doctors were able to say definitively what somebody's prognosis was. That would be bewitchingly simple, and in that case we could dispense with a lot of the discussions around this. It frankly isn't true. Any doctor who feels that they are able to adequately predict in terms of months and years what somebody's prognosis is usually mistaken. As I said, this week I've seen 3 people that I thought were going to be dead who aren't, and it's very much imprecise. And until we improve on the precision and accuracy with which we can identify somebody's prognosis, then it's meaningless to include in the bill, because you'll find, in a room of 10 doctors, you'll have 10 different opinions.
Do you feel the point raised by Mr Hazelwood regarding Section 23, subsection 2, which gives power to Scottish ministers to define guidance or even provide some more sort of specific regulation around what qualifying criteria might be, gives you some comfort that that could be a evolving situation, that would allow greater definition through secondary legislation?
I think that the primary legislation should have a definition that is agreed and acceptable. I think we shouldn't pass it in principle and then try to fix it in secondary legislation.
Thank you very much. Mr Akasha and Mr Arunpul, do you have any views on the definition of terminal?
I'm very happy to. I would also echo the point that I am not a clinician, but can reflect the views of those clinicians that I work with who are very skilled in this area. I think when it comes to young people, prognosis is even harder. Many of these conditions are rare, not often seen. The course of illness is unpredictable, and the rate of medical advance is really astounding. So I might give the example of something like Duchenne's muscular dystrophy. So perhaps 10, 15 years ago, Chas would have supported many young men, usually men, with Duchenne's muscular dystrophy, because they would be expected to die in their teens or perhaps very early 20s. The rate of medical advance now is such we support very few people in those circumstances, because longevity has improved to such a point that there are people who are now perhaps have that diagnosis who are living into their 30s and in some cases beyond. So the rate of advance is significant. So the point you make about the flexibility that is afforded in the bill and the enabling powers for ministers, I actually take a different view on it. I think they are concerning and would allow changes and expansion to the definition without the type of parliamentary scrutiny that you are providing today. I think the definition is fundamental to the bill. If you cannot describe in the bill who is the population that is encompassed by this, then that is problematic. And I think more work is needed in that area.
Do you have a view on what amendments might satisfy you regarding the definition?
I think it's a very difficult question to answer, and I don't have a simple amendment because the issue is not simple. The issue is complex, and it goes to risk, it goes to ethics, and it goes to some very fundamental decisions that you and MSPs will need to take on behalf of society about how far we are willing, what level of risk is going to be acceptable in a regime which allows assisted dying.
Mr. Rimple, just wonder if you had any comments on this at all.
Just two brief comments. Again, making it clear that I don't have any clinical training. In terms of the definition as was, to add to the point that Mark made earlier, this was developed as a part of a campaign by Marie Curie, among others, deliberately as a broad and inclusive definition that deliberately did not include prognosis in order to enable people to have access to financial support they need when they get a serious illness, without having to have a prognosis agreed by a doctor to say that they were in the last 6 months of life, enabling to get the DS 1500 form as was from the Department of Work and Pensions. That's what this definition was developed for. That doesn't mean that it's an appropriate definition for other legislation, any other legislation that is about people with terminal illness or at the end of life. So it was very deliberate. The other point is to reinforce something that Sarah Mills said, which is that in terms of the numbers of people dying in Scotland and across the UK, the fastest rising cohort are the over 85s, people who wouldn't have a diagnosis of a terminal illness or a diagnosis of any terminal illness, but have a little bit of kidney failure, and they're very frail, and they're in pain, and they have a wee bit of cognitive decline. And this is the group who my reading of it, and our reading of it at Marie Curie, is that they would be excluded in this definition. So the answer to your question could be that the definition might be both too broad and too narrow, and that it maybe does need to be looked at again. But that is a question for yourselves. But you might want to decide who you want included first and who you want excluded first, and make sure that you're drawing a definition around that, rather than necessarily using something that was developed for another piece of legislation with a very different intent.
Just finally,
Mr. Sweeney. So if you've got a very brief question, I can let you ask that.
Convener, it's just regarding the European Convention on Human Rights, regardless of what the bill defines as a terminal illness, there may be scope in future for the courts to extend that. Is that something you have concerns about? If anyone has a view on that.
That has been something that has certainly happened in other jurisdictions, and I would say that it comes back to the necessity to have a definition which delivers the policy intent that you as parliamentarians wish, and at the moment that's not there.
Okay, thank you very much.
I would say I absolutely agree with that, and I think that if the bill is passed in with the wording as vague as it is, that it's inevitable that would happen.
Okay, that's helpful. Any other comments?
Yes, to echo others, I think that the definition is imprecise, and I think that leaves it particularly vulnerable in terms of legal challenge or interpretation. So that is a concern that we've raised in our submission.
Thanks very much. If there's no further comments.
Thank you, Mr. Sweeney. I want to move on. We've touched on this very, very briefly about the age of eligibility. So I suppose the very simple question is 16 an appropriate minimum age to make a decision on assisted dying?
If I may Art, our view on that is no, that there has been insufficient consideration given to the appropriate age. The rationale for the age of 16 in the bill is unclear, and it would make Scotland an outlier for a bill of this type, which is based around terminal illness, as opposed to some of the international comparisons which are based around unbearable suffering. And so it would become an untested area. And what I would say, Convener, is that there are many precedents in Scottish public policy for a higher threshold for adulthood on grounds of vulnerability. And I suppose what I would say is you have to be 18 to serve on a jury, to buy alcohol. You have special considerations that are put in place if you are a young adult wishing to donate an organ through the Scottish Transplant Programme for reasons of vulnerability. And I suppose what I would reflect on is that the legislation which the Parliament passed, a laudable legislation around the UN Convention on the Rights of the Child, recognises that the age of adulthood begins at 18. And there is a range in Scotland, and there is a recognition in the child protection legislation that there are very nuanced decisions in that age between 16 and 18. And I would say that this is an area where caution is needed. One of the reasons, for example, why in the Scottish courts sentencing decisions are different for people up to the age of 25 is that there is a recognition that the brain develops over a period of time, and it doesn't switch on at any one particular age to being an adult. And we know that younger people are generally considered through the sentencing guidelines to be less able to exercise good judgment in really complex decisions. That is why those decisions are set out differently in the sentencing guidelines. There is a risk around younger adults, particularly around the ages of 16 to 18, being more susceptible to negative influences, to more difficult relationships, less able to think about risk. And so across a range of policy areas, you as parliamentarians have set different age ranges. So I would say be wary of any easy answer and saying, oh, well, it's this for that, so it must be that for that. You need to think, I would say, what the facts of this issue are and come to an appropriate decision which reflects the gravity of the decision, the risks that are involved.
I don't know if anyone else wants to add to Mr. Okash's comprehensive answer. No, it was very you actually answered two of my next questions, so thank you.
So I would say in that respect, from an academic perspective, the majority of papers written on this area would exclude people under the age of 18 and sort of focusing on adults only. So if you're looking for a research base to underpin your decision, the majority of the research would not include 16 to 18-year-olds.
Did you want to add?
Just to say that SPPC concurs with and supports the view that Ram has expressed.
Marie Curie is an adult provider, so we have to take a neutral position on this. And but we are not, just because we are not the experts on children and young people's palliative care. CHAS are in Scotland.
Mm-hmm. Mm-hmm. Okay, that's great. Thank you. And Joe Fitzpatrick.
Sorry, it was David Thomas.
Oh, sorry, David.
Thank you, Convener, and good morning, everyone. In evidence session from Canada, family members or loved ones had opposed the process for assisted dying. So should family members or loved ones be involved in the decision-making for assisted dying?
Could I just ask you to clarify, please? Do you mean that they would have to consent to a family member having an assisted death, or they would be able to raise an objection that would have an impact on whether they could or not? Is that what you're asking about? Yes. I think that's a very interesting idea. What I would say is that my colleagues who are delivering palliative care deal with family conflict about decisions, because there are decisions made in palliative care provision, kind of quite regularly. For example, and Sarah can maybe talk more to this, but between the balance between, say, sedation to manage somebody's pain symptoms, and the desire for, kind of their view of their quality of life is that they want to, kind of maintain an ability to socialise with friends and family, for example. And you have to make a decision. You have to prioritise what's most important to that person. But you would always prioritise the wishes of the person and not their family members. Their family members and carers have a very important contribution to make to somebody's care. But as we are talking here, depending on how it's defined, about adults who have capacity, and I know that there are big questions around that, but very basically we are talking about adults who have capacity. It would be that adult who would make their own decision. And I find it, yes, it's an interesting idea because it doesn't, and it raises the question about whether assisted dying is a medical treatment or not, because in other medical treatments there would not be, you would not have that, that role for family members.
Anybody else?
So under the terms of the bill, there's, I don't think, any mention of family. So it's not something that the bill addresses. I suppose also just to say that not everyone has a family, of course, or even a range of social networks. I think it is a tricky area, as Amy has said. Part of palliative care encompasses the care of people around the person who's approaching the end of life. And I guess it's not clear what applies here. I can envisage there being a range of circumstances that seek to balance the person's, the needs for patient confidentiality and autonomy with what may be very complex and contested and conflicted views amongst the surrounding social network. And just to say, I think there's another element thinking about family involvement in assisted dying, which comes back to something which I don't know whether we'll get on. I think it's not the intent of your question, which is around the understanding of the circumstances where somebody may being coerced. But I think that's probably not what you're thinking of.
I mean, certainly in that respect, if assisted dying is a medical treatment, an adult who has capacity to consent for themselves, we wouldn't necessarily take the family's views into consideration for that. As part of palliative care, we do frequently have discussions with patients and families, and consented decisions are often made and often form the basis for anticipatory and future care planning, which we keep as records. But certainly if somebody had capacity and the family were objecting, I would expect that in Scotland a consenting adult with capacity would have the right to consent to a medical treatment, irrespective of their family's views. My main concern in terms of role of family would also very much be in terms of coercion, and in terms of the role the family was playing that the medical practitioner may not be aware of.
For young people and young adults, the family is often, but not always, the primary carer for that person, and so the relationships are a little different. I think my concern is perhaps less about coercion, but more about the feeling of burden and the fact that I have heard in cases people talking about the risk of being a burden on the family. That should be a worry, and I hope that would not be a consideration. One of the challenges, though, in the detail of the bill around that is that the capacity assessments that we look at would allow someone who has capacity, meets the definition, and whose sole motivation for an assisted dying is not wishing to be a burden, to exercise that. And that seems to me a big step that the committee would want to think about whether that is a reason which would be justified for an assisted death. And in relation to families, I suppose, and young people, there is a question about the degree to which the doctor who is making the assessment knows the family. or knows the person, or indeed knows the patient at all, and there is no requirement for them to do that. So a doctor who has no knowledge of the patient or the family history beyond a set of medical notes in front of them would be asking to make very complex decisions about capacity and motivation.
If a loved one makes a request for assisted dying, should it be a requirement for a family to be informed?
We've not done any work on that. So that would be different to anything else. Is, I think, as far as, but I think you would know that that's not a requirement for any other treatment for somebody, for an adult, of course.
And speaking back to your point, not everybody has family, and not everybody's biological relationships are their emotional relationships. Certainly there's some families where informing the family of any medical decision would be completely wrong and very much against the patient's wishes, and others where the family is very informed and where the patient would expect you to phone them, and very much encourage that. And I think it's not possible to put down in black and white who should be informed at what juncture and when. I would also argue that would significantly increase the amount of time devoted to the enactment of this bill. Certainly if I'm phoning family members to have a palliative care discussion, I would usually allow half an hour for that. And that's sometimes not enough time. So you're already talking about a lengthy process. And then there's the decisions of, well, if you phone first degree relatives, do you phone secondary relatives, and what about the cousin in Australia, and where do you draw the line?
Thank you very much. Can I thank the panel for their attendance today and for their evidence, and that concludes the public part of our meeting today.